what cannot be ignored is that we love salt, and we eat a lot of it, especially in processed foods like chips and baked goods. PepsiCo claims to have developed a salt that tastes just like salt, but it's not as bad for you. We asked Sean Cole to visit PepsiCo headquarters, and we absolutely insisted that he bring an appetite.
Hello, sir.
How you doing?
How are you?
Nice meeting you.
What is your name again?
Greg Yep.
Greg Yep is PepsiCo's Senior VP of Research and Development. We met up in a boardroom at the company's headquarters in Purchase, New York. This is great. We have water and we have chips. Bags of test chips from the lab, and I'm going to taste them. The first bag is just classic Lay's with a third of the salt removed. The second bag is the same, but it's dusted with a PepsiCo invention called crystal salt. It's a more soluble form of sodium chloride. Because Yep says with normal chips,
A lot of the salt is not actually tasted. It doesn't dissolve as efficiently on your tongue. When we design crystal salt, you actually taste more on your tongue, so you can use less, and it gives you a more salty flavor.
So the idea is the crystal salt chips should taste saltier, more like full salt classic Lay's. Because for one thing, crystal salt is a lot finer than regular salt. And maybe it's because it wasn't a blind test, but I couldn't really tell the difference. Moreover, PepsiCo says sales of full salt classic Lay's are doing fine, so why go to all this trouble?
That's what the consumers are increasingly asking for. One, I want healthier products. Two, I don't want to compromise on the taste.
Mahmood Khan is Chief Scientific Officer at PepsiCo. He's also an endocrinologist. He used to work at the Mayo Clinic. He says the Crystal Salt Initiative is part of a larger goal.
We've made commitments to lower the salt content by 25%, lower saturated fat, and lower sugar across our portfolio in our top markets. It makes good business sense. It makes good consumer health and wellness sense.
We're talking about potato chips here. We're not talking about a health food.
Marion Nestle teaches nutrition and public health at NYU.
And the philosophical question that you have to ask about these products is a slightly better for you option a good choice? When what you really want is you want people eating foods that are unprocessed as possible.
Professor Nestle told me sure, a third less sodium in a bag of chips is positive. But she also says maintaining the same salt taste as regular Lay's defeats the purpose.
Because the purpose of the reducing the amount of sodium, besides the health effect, is to try to get people's salt preferences lower so that the amount of salt that's in products at a much lower level will taste salty to the people who are tasting it.
Case in point, Nestle lowered her salt intake years ago. Everything tastes too salty to her. Conversely, my taste buds are apparently shot. I brought some classic Lay's with me to the lab and couldn't tell the difference between them and anything else I tasted.
They're yummy, but they don't taste saltier.
I should mention that a bag of classic Lay's has 170 milligrams of salt per 1 ounce serving, which is not dramatically high. But I bet you can't eat just 1 ounce. In New York, I'm Sean Cole for Marketplace.
I'd like you to think about this whole idea of producers of illness and us being the consumers of illness, and thinking about the fact that we've got lots of people making money off of illness. Another concept that the conflict perspective looks at is the idea of medicalization. Now, let me explain what medicalization is. Medicalization is looking at a certain behavior and saying, you look at it one way, but we're going to say this behavior falls under the domain of medicine. Medical doctors should deal with this problem and have the best way of dealing with it. So if you think about something like anorexia, medical doctors are saying, that's us. We can fix anorexia. We can deal with anorexia. Of course, this goes back to the upstream-downstream thing. Who benefits from medicalization? All those medical doctors. How do they maintain that benefit? Well, every day when we think, oh, we've got a problem, let's go to a doctor and fix it, sort of one person at a time, we are maintaining the benefits of the doctors. When we come together and say, this isn't a personal problem, this is a public issue, that's when we can start to change things. But as long as we keep on thinking in terms of individuals, I have a problem with anorexia, she has a problem with anorexia, we're both going to go to doctors and doctors are going to help us, that sort of, that individualized approach is not fixing the problem, it's maintaining their benefit. So here's a little history on the background of medicalization. An example is pediatrics. Prior to 1950s, pediatrics treated children under age 12. At this time, there's a lot of vaccinations. They started vaccinating kids. And pediatricians were pretty much left dealing with the common cold. Kids were not coming to them with measles, mumps, rubella, chicken pox, and, basically a kid would start to get a cold, go see the doctor, and the doctor would say, oh, okay, drink some fluids and eat some chicken soup, and, I'll take your temperature. Pediatrics was redefined during the 1950s. First of all, they expanded their domain. They said, we can treat kids from birth to 18 years old. More clients. Second, they started medicalizing children's behaviors. They started saying, temper tantrums? We'll solve that one. Come bring that problem to us. Bedwetting? Ooh, medical problem. We'll fix that one too. Fears, phobias, shyness, thumb-sucking, nail-biting, school problems, traumatic experiences. All of these things were now things that you can go to a doctor, and a doctor would help you deal with as a parent. Let's look at some other examples. Eating disorders. Again, medical doctors come along, they say anorexia, bulimia, we can fix that problem. It's a great source of income for medical professionals, but from this conflict perspective, that's fixing the problem downstream. It's looking at these individual men and women who are anorexic and bulimic and saying, let's treat them. The conflict perspective would say, when you medicalize an eating disorder, you are obscuring, you're hiding the cultural roots in society's standards of beauty for women. When you see the Hollywood women and the supermodels who are all stick thin and showing us that's beautiful, for the conflict perspective, those cultural meanings of what beauty is are the problem, not the women who are sort of the victim of anorexia and bulimia. When you learn that somebody has anorexia or bulimia, do you look at them and say, oh, I blame them for their problem, they should have fixed it themselves? No, because their behavior has become medicalized. We look at medical conditions and we sort of excuse people for their behavior because we say they've got an illness. It becomes medicalized. We excuse them from it. What about medicalizing attention deficit hyperactivity disorder? Well, again, lots of money for doctors, insurance companies, and pharmaceutical companies. We'll put your kid on Ritalin and we'll fix you right up. But again, we're obscuring the possible roots of children's behavior, inadequate parenting, stultifying schools, and even gender socialization. We are looking at this illness, which doctors have invented. Attention deficit disorder did not exist forever. Doctors at a particular moment in time said, ADHD, it's a disorder. But what about the other possible causes that might be more social in nature? Maybe you've got a little boy who runs around like crazy. Is he being a little boy because he's been taught that boys run around like crazy and boys are wild and boys should jump all over the place? That would probably be an issue of gender socialization, not a medical problem. What about parents who are not engaging their children? Again, the kid might be bouncing off the walls, but he's dying for somebody to engage him and talk to him and get his mind going because his body still is going. Or what about a kid that needs to be on a soccer team or a basketball team, but his parents aren't interested in doing that? So the kid's bouncing off the walls, get him on an organized sports team, problem might be solved. What about the schools being the problem? Kids bouncing off the walls, they're being told to sit down, shut up, and not talk. Well, the kids might be bouncing off the walls for that reason, some kids. They're medicalizing the behavior, making money off of it, and sociologists are saying, what if it's the environment? Keep that in mind. What if the environment needs to change? The last example we have, I'm a little bit biased on this one, is the medicalizing of obstetrical care, which basically is the idea that in the past, women went to midwives. Midwives would, basically they're baby catchers, and they call themselves baby catchers. The woman pushes, the midwife catches the baby, the father snips the cord, the midwife makes sure that the baby's okay and the mom's okay. Very simple procedure. My wife has delivered 2 children with a midwife. Our second child was delivered in our home, and it is not a medical procedure to give birth to a child. It's very natural, and doctors are turning it into medical interventions. If you've looked at the data on C-sections, cesarean sections, doctors are cutting women open at very high rates, and they're scheduling pregnancies. They're saying, I want you to have this baby, boom, we'll get it done on a Monday, and, we'll have your baby. A lot of sociologists have looked at the days of the week where babies are born. Doctors are not scheduling cesarean sections on weekends because they like to have their weekends off. They don't want to work on weekends, so they don't schedule them on weekends. So you've got a whole crop of children who are not born on weekends because doctors don't schedule it on weekends. Again, it's money-making and it's controlled rather than it being natural. A lot of people look at childbirth as this scary thing, and when you do it with a midwife, when you give birth with a midwife, they talk about how natural it is to give birth. There should be no fear involved. You love your child, you love your husband, and it's not a medical procedure. You are doing what people have done for a very long time. But doctors have stepped in. They want women to lay on their backs, which is not a good position for women to give birth. Gravity should be used to help a baby come out. Women are on their backs, and doctors used to use things like forceps and cesarean sections. Again, it's all medical procedure, and they're making lots of money. We've got some data on infant mortality and the mother's race and ethnicity. And these are just some numbers to get you to see that the environment and the social factors do matter. African American women have higher rates for infant mortality. Whites have rather low rates, and Asians have rather low rates. And it's basically an issue of class and of money, and an issue of information and how doctors look at you and your access to health care. These things all come together. It's not about biology. When sociologists learn about biology and they compare biological explanations with environmental ones, we tend to find that the environmental ones make more sense. The last example we have here, the consequences of health stratification, are health outcomes. When you compare whites and African Americans and death from cancer, African Americans are dying at a 25% higher rate. When you compare death from heart disease, African Americans are dying at a 50% higher rate. Death from stroke, African Americans are dying from a 50% higher rate. Diabetes, African Americans have a 200% higher rate. HIV/AIDS, African Americans have an 800% higher rate. And infant mortality, African Americans have a 200% higher rate than whites. When I show you this data, I want you to realize that I'm not saying there's something biological about African Americans that make them different. All of the research that I've read on race says that whites and African Americans are more alike than different. Skin color is one factor, and it's very small. African Americans and Caucasians are more, biologically speaking, are more alike than they are different. So it's not a biological cause that are driving these things. It's an environmental one. And a lot of medical professionals want to step in and say, African Americans have higher rates, and it's because of their genes. But I've talked to a lot of biologists about this, and environment can change your genes, first of all, and second of all, environment impacts your health. Where you work, where you live, whether you have health insurance, whether you don't, all of these things will shape whether you live and whether you die. Do you look at medical things the same way as you do other things? When we talk about crime, somebody in the class said, we should just shoot everybody who's in the prison. Why don't we look at medicine that way? Why don't we say, all these people who have, diabetes, they did it to themselves. Let's take them out and shoot them. All these people who have anorexia and bulimia, well, they're just stupid. They don't understand that they're actually thin. Let's take them out and shoot them. Do we look at medical problems the same way? What about mental health? When somebody has depression, do we just want to say, man, you're doing it to yourself. You should just decide to be happy. When we look at issues of health and illness, do you blame the individual, or do you recognize that there are higher powers, whether they're biological or environmental, that are causing that problem? So if you do that for medical, why don't you see crime and poverty the same way? Where there is a higher power, whether it's government or corporations or working or education or something, that are causing people to go into crime or to become poor. Why is it with medical things we tend to excuse people more so than with something like crime or poverty?